Older in infectious diseases, University of New South, member Thyroid Society of India, and she's been actively taking part as a faculty speaking in this semester. Welcome.
Thank you very much, sir. Very good afternoon to one and all present here. At the outset, I'd like to thank the chairpersons and the organizers, especially Dr. Kumaravel, for having me over here. And it is completely heartening to see a packed hall on a Sunday afternoon. I think that itself speaks about the quality of the conference right from the morning of being there. In fact, I actually regret not having been there yesterday. So I think it's hats off to the organizers. And it's no mean task to follow a speaker like Dr. Krishnan Swaminathan. I think he's just, he must have really enthralled all of you in the last 20 minutes. So shifting gears, I would be talking about CGM and AGP, advantages and limitations. Now, when you talk about monitoring of diabetes control, generally we have the venous sugar measurements that we traditionally do, HbA1c, and then you have the SMBGs, and the new kid on the block is TIR, right? So what we are concerned today is, can treatment decisions be entirely based only on HbA1c and SMBG, or do we need to learn more about CGMs and AGP? That is what we're trying to address. And what are the problems with HbA1c? All of us understand that this is definitely the gold standard. This is not going anywhere for the next few years to come, so definitely HbA1c is there to stay. But we need to understand that for a given HbA1c, there can be a wide range of mean glucose concentration values. As you can see, somebody with an A1c of 8% could have high glycemic variability as is projected here. And the same thing, somebody can have a narrower bandwidth. So it is always not true to take HbA1c by face value. You do have to understand that there could be a lot of glycemic variability when you look at an A1c value. And it does not reflect acute glycemic excursions and conditions like anemia, especially in our part of the world. I think every other person that we see in the OP is anemic, not to talk about hemoglobinopathies, pregnancy, liver disorders, CKD. All that is again going to confound the A1c measurement. So all these things have to be taken with a pinch of salt, when you look at an A1c value. So what about SMBG? I think SMBG has really changed the way in which we monitor diabetes today. In fact, most of our patients are quite well versed with an SMBG, but it again shows only a single point in time measurement and does not provide data on the direction or the rate of change of blood glucose levels, and the data is entirely based on the patient's adherence to self-monitoring. So unless the patient decides to check, you do not know. Right? So the patient has to be extremely motivated to keep doing SMBG on a frequent and on a particular time of the day, or in a particular frequency. So if the patient does not check, you do not know. So that is a major shortcoming of SMBG. And again, this looks beautiful, right? It's all in the range that you want, but when you actually do a CGM and C, you could have a lot of fluctuations which can go unnoticed on an SMBG sample. So, in other words, when you do a finger stick, what you miss is this unnoticed high or an unnoticed low, which is what largely makes a difference when it comes to glycemic variability. So these are the things which become shortcomings when it comes to monitoring blood glucose levels in the traditional way. So therefore, you have two options. Either you step forward into growth or step back into safety. So nobody is saying HMBG or HbA1c is not there. It is just that we need to change with changing times, and that is why we need to know a little bit about CGM and AGP. So the traditional barriers to glycemic control has always been chronic hyperglycemia, but that said, today glycemic variability and glycemic instability happen to be a very important part when it comes to the complications in our patients with diabetes. So this is the classic analogy that has always been used when you talk about an SMBG and a TIR. And SMBG is like taking a snapshot. It's just a photograph. All you have is the measurement. It is just like looking at a photo. You do not know what happened before. You do not know what happened after. But a CGM is something which gives you a videograph. It is like seeing a video. It is like understanding in what context things are happening. But to just take it one step forward, I would even say a CGM is something like a Big Boss camera fitted inside the patient's house, right? That is what Kamal says. I'm watching you all the time. Right? That is exactly what CGM does. You are able to put the patient on a CGM, send him home, ask him to come back with data. You sit and look at the AGP profile, and you're able to really understand where the patient went wrong or where even your therapy could have gone wrong, right? So that is what we try to do when you do AGP in our patients. So what is CGM? The first approved CGM was in 2005, and you were able to obtain a complete glucose profile by measuring the interstitial fluid glucose levels every 5 to 15 minutes, giving us something like 96 to 288 measurements in a day. So you are able to directly observe the glycemic excursion and also bring in therapeutic and behavioral changes in the patient in order to reduce the complications. So AGP is basically a visual means of representing all the CGM data on one sheet of paper, right? So you have everything in front of you, and all you need to do is just start the conversation. Just start talking to this patient where things are not fitting in and where you or him can make a change in order to affect the management of diabetes. So the large or the broad indications for CGM would be one for a short-term diagnostic tool, long-term therapeutic tool, and when you want to make large glycemic status assessments and therapy adjustments in this patient. Brittle diabetes, that again is an area where CGM really comes in handy. People on flexible insulin therapy, physical activity. I mean, most of you could have even seen a lot of sports people wear a CGM when they come out to play. So that again becomes a rough indication of what a particular sport or physical activity has impacted as far as the sugars are concerned. Pregnancy again. And when you have large discrepancies between HbA1c and the SMBG values, and people that could have variable glucose profiles, that is patients on dialysis, patients on people on shift works, people who travel more. So these are all patients in whom CGM can be very, very useful. And the types of CGM we have, broadly speaking, you have a professional CGM which is blinded, wherein the patient comes to the professional for scanning the CGM every time, and then you have the readings in front of you. The flash is again an intermittently viewed CGM where the patient can have the sensor and the scanner with him and then scan it every other time and get the readings as and when he wants. And then you have the real-time CGM, which is completely linked to your smartphone or your device, wherein it keeps taking the measurements and it keeps giving you a real-time picture of what is happening. Now here you can also set a hypo or a hyper alarm, and then that even makes things much easier for the patient to tackle. So some of the core CGM metrics that we need to understand when we see a graph is that you have the number of days that the sensor is active. Generally we put it in for 14 days, and the percentage of time that the sensor is active. You at least need your sensor to be active for 70% of the times, and the mean glucose concentration, as you can see here, and the GMI or the glucose management indicator, which is nothing but the estimated HbA1c, which can be derived by looking at all the 14 days data. Then of course we have the TIR, which is the time in range, which is the percentage of time that the patient spends in range, which is 70 to 180 milligrams per cent. So you want your patient to spend more than 70% in a day within the range, which is 16 hours 48 minutes. And TAR level 1 is the percentage of time when the glucoses are more than 180, level 2 is when it exceeds 250, so on. You also have a time below range, where level 1 is less than 70, and level 2 is when the blood glucoses drop to less than 54. So you do not really want your patients to dip below range, so you're not even okay with even 1 hour spent below range, and below TBR level 2 is hardly 15 minutes a day. So these are the targets when you look at interpreting a CGM graph. Glucose variability is, as you can see, this is the graph that you're presented with when the patient comes to you with the AGP profile. So the variability is assessed as a coefficient of variation of the glucose measurement, and generally this has to be less than 36%, and this is a calculated value which is derived from the data that is presented to the CGM. And this is the median line, where the green line, where 50% of the readings fall above and 50% fall below. And then the dark blue shaded one is the interquartile range, which is the 25th to the 75th percentile, or the range in which 50% of all the glucose reading fall, that is 25% above and 25% below the median. And this is the light dotted one. This broader one is the 5th and 95th percentile, where 90% of all the readings can fall. So what is it that TIR and HbA1c mean to you? We need to understand that TIR and A1c are inversely related. In other words, higher the TIR, lower the A1c. So somebody who spends a lot of time in range will have a lower HbA1c, right? Now this is derived from all these things. So 70% TIR roughly correlates to a 7% HbA1c. And every 10% change in TIR or an increase in TIR correlates with 0.5 to 0.8% HbA1c reduction. Now how does that matter? I think every single percentage matter, right? We just saw what the weight of 100 grams was. An Olympic gold medal was shattered by just 100 grams. So that is what happens when you try and work on even 1% change. I think you were able to just reset a 15-minute lapse either in hyper or hypo, and you really can make a lot of difference to the quality of care that you provide. So nothing is too low or nothing is too small. It's just that you need to educate your patient that this can be changed and this can be improved in order to reduce complications and improve the quality of life. And of course, TIR also helps you to contextualize HbA1c. It is not just a stray number that you see. When you see an A1C with a TIR graph, you know that this is an A1C of 6.3, 56%, 31% above, 13% below. Again, an A1C of 6.3. You have 60% time in range, wonderful. But look at the time below range, 10%. So I really have to work on the time below range. So it kind of gives me a starting point of where I should really begin working on as far as the patient is concerned. So that is the context that the TIR is able to give you. So based on all this, you have different targets for different diabetes populations. As I discussed, 70% is what we strive for in most of our patients with type 1 and type 2. In elderly people where the targets can be a little more relaxed, you can keep it at 50%, but when it comes to pregnancy, GDM, or a type 2 who's becoming pregnant, 90% of time has to be spent in that range. And as the TIR drops, 10% drop in TIR has been correlated with a 64% increase in the rates of retinopathy, 40% increase in nephropathy, and 25% increase in neuropathy. And carotid intima media thickness is also being related to TIR in ongoing studies. So these are all the different studies that have evaluated the effect of TIR on diabetes complications. And when you actually look at the 10-year incidence of complications both in type 1 and type 2 by improving the TIR, you find that as the TIR improves from 60% to 70% to 80%, be it type 1, be it type 2, you definitely have a better prediction as far as the incidence of complications are concerned. So the rates of complications do come down, be it MI, be it ESRD, be it severe vision loss, amputation, everything improves as the TIR improves. But according to me, the most important place where a TIR really comes in useful is to effect a behavioral change in the patient. Because the patient is, after all, able to see for himself where things are working and where things are not working, which food suits him, which food does not suit him. I mean, from time immemorial, we've been talking about individualizing diabetes care. How do you individualize? Unless you have something like this, you cannot individualize even a diet chart, right? So that is where TIR is really useful. And when you look at the graph, you want a flat, narrow range like this. Whereas when you see a broader interquartile range, you really know that there is something wrong in the therapy that you're giving the patient. When you find a broader outer range, you know that something is happening from the patient's side. Maybe he's missed an insulin, maybe he's forgotten the afternoon dose, maybe something is wrong with the lifestyle. Or when everything is haywire, then you really have to talk to this patient. So it kind of gives you a very, very impactful and insightful message as to where you have to start the discussion. What about the patient's perspective? Does TIR matter as far as the patients are concerned? Yes. Now this was a study where they looked at what all factors could have a big impact in day-to-day life in patients living with diabetes. And right after food choices that they made, TIR was a very, very impactful tool when it came to how patients really looked at what they can do to improve their quality of life. So again, that is something that matters. And they also felt that the performance of TIR was much better in preventing negative time and range outcomes more than even improving positive time and range outcomes. So if I phrase it differently, they were able to avoid hypoglycemic events by following a CGM rather than even preventing hyperglycemia. I think that is definitely the Achilles heel when it comes to management of diabetes. You prevent one hypoglycemic episode, I think you've really done a lot of good to this patient. I think that is where all this is really, really effective. So much so, TIR is emerging as a standard of care in diabetes management, and there is a lot of data which is probably looking at TIR as an acceptable endpoint in diabetes clinical trials. Of course, everything comes with its limitations, and I cannot, forget the cost when it comes to CGMs. Now we are in a world, we are in a country especially where, you just heard from Dr. Krishnan Swaminathan, you have people, most of the people living below poverty line, they don't even afford the drug, then what is the point in talking to them about a CGM, right? So definitely cost matters. I really cannot move away from the fact that it is a very, very expensive tool and it is not covered under insurance. Unfortunately, outpatient management in India does not fall under insurance. So again, there is a major block out there. Accuracy is also a concern, insertion, adhesion, removal difficulties. So when you look at a type 1, naturally when they have a little bit of social stigma and going out with a sensor in place, it becomes a little, delicate for the child also to be explaining to everybody that he or she has type 1. Skin irritation, itching, sweat, water, somebody can be a swimmer, they may not be able to use a TIR. Now these are all small things but actually matter in a large way. And drugs like acetaminophen, vitamin C, dopamine, mannitol, all of them can interfere with TIR. And X-ray, CT, MRI, I mean, I've had patients who have gone into an MRI, come out, the TIR is completely off. You know, those are all things which can interfere with the quality of TIR that you have. And there's always a measurement lag between the interstitial fluid values and the blood, which is around 7 to 15 minutes. And the DTS, or the Diabetes Technology Society guidelines, recommends to avoid CGM in the inpatient setting when you have extremes of blood glucose, say somewhere between 440 to 500, or somebody in DKA, somebody who has a peripheral circulatory failure, somebody with a lot of fluid and electrolyte shifts, significant edema, vasoactive agents. Now, these are all people in whom you cannot use a TIR. And if the detection threshold for hyperglycemia is too high or too low for hyperglycemia, there is a risk of frequent alarms, isn't it? So naturally, an alarm fatigue is yet another point. If the alarm goes off for every moment for a trivial increase, then the patient naturally becomes quite frustrated. So much so that he can even neglect a true alarm. So that again is a major concern with the real-time CGM. And there is always an inverse relationship between sensitivity and specificity, and that can again lead to a lot of frustration. And the most important point being that most of the data that you have on complications in TIR has been extrapolated from the data that we had from DCCT. So the DCCT already had a 7-point SMBG, and what these people did was actually to plot it on a TIR graph, and you have retrospectively investigated the data, and from that they have given us outcomes for retinopathy and microalbumin. So naturally, whether long-term CVOT and TIR trials are related, now we are not too sure of that. And definitely complexity and the clinician's reluctance due to lack of experience in interpreting a CGM data. Now, accept it. All of us have to finish the OP on time and go home for lunch on time, right? That really becomes a major limiting factor. So when you have a patient coming in with an AGP report as the last patient of the day, I'm sure it is going to be a little difficult, right? So there is a lot of data that you have to sit down, there is a lot of data that you have to get into, talk to the patient, discuss. It is not easy. It is time consuming and it is quite complex. So unless you do it on a regular basis and unless the patient is also adept at doing it, it does make life a little difficult at times. So to conclude, guidelines and consensus recommendations on the use of CGM-based metrics in routine diabetes care have been developed. When compared with traditional glucose metrics such as HbA1c, the CGM data reports can give additional glucose measurement values such as TIR and glycemic variability. TIR, time above range and time below range, is a powerful metric for capturing dynamic fluctuations in blood glucose levels. But an ideal CGM should be that which is rapid, accurate, free of interference, inert, robust, cost-effective, and minimally invasive. And lastly, if you really want to close the loop, you must have an artificial pancreas where the CGM is also linked to your insulin pump. I think that is where we talk about precision medicine. Like Einstein said, computers are incredibly fast, accurate, and stupid. Humans are incredibly slow, inaccurate, and brilliant. Together they are powerful beyond imagination. I think I'll stop there. Thank you very much for the opportunity.
Thank you, madam. Nice. We had a very interesting session. 3 topics open for discussion. Just 10 minutes for discussion. I think I will start with the Krishna Swaminathan to repeat the rhyme. 10 foods to avoid.
அதாவது இப்போ தூக்கத்தை என் பொண்ணு வீடியோ எடுக்கிறா, இது அப்படியே சொல்லிகிட்டே இருக்கேன். பிஸ்கெட், பிரெட்டு, ரஸ்க்கு, பன்னு, பேக்கரி ஐட்டம், ஸ்வீட்டு, சிப்ஸு, முறுக்கு, மிக்சர், கேக். ஓகேவா? என்ன அவாய்ட் பண்ணாலே ஏழுக்கு வந்துடும். Regarding breakup consulting issue.
But more common is the diphtheria vaccine. And at that time, we are not sure what vaccine was given to us, whether it is reduced diphtheria vaccine for adults or it was routine diphtheria vaccine. So some of us developed a bacterial toxicity, but fortunately we recovered. But it can go to the tune of producing motor weakness also. So we have to be quite careful regarding that and better use reduced diphtheria vaccine for adults. It's not routine diphtheria vaccine.
For Lakshmi ma'am, because this is going to be a higher end investigation. For a country like India, we have any specific indications selecting patients apart from type 1 with the on insulin. In type 2 can have any specific. And number 2, one more question, because the last topic is going to be covered by Dr. Kumarvel. All patients are very happy about the reversal of diabetes. And the most important thing is intermittent fasting. Whether you have any data for patients who are on intermittent fasting, their TR also. Whether you have any data.
Yes, sir, absolutely. I think both can be answered by only one thing. Even if you want reversal, even if you want something good, ultimately what has to start is a behavioral change. Right? That is what is going to be the stepping stone for even remission. Unless the patient decides to drop weight, unless the patient decides to change behaviorally, I mean, even the 10 foods that sir mentioned, and that has to be motivated to the patient, and that is where a CGM comes in. Right? Sometimes the patient is really, sometimes they don't accept it. They only say that the A1C is high. They really don't tell you where all they slipped. And when you put in a CGM, you're at least able to tell them that these are the places where they can improve and they can probably work on. So in the type 2, in people who have very difficult to control diabetes, brittle diabetes, people who complain of nocturnal hypoglycemia but it has not been documented, in patients with a lot of fluctuation, these are patients in whom even in type 2, I have used quite a bit of CGM and it is very, very useful in that sense.
Good question. Have you encountered any patient that has got a HbA1c of around 9 but persistently normal CGM? There is a group called hyperglycatus. Have you encountered such patients so far?
I have not encountered so far. I would like to hear from. I have not encountered a line with a normal CGM. Not so far.
Sir, regarding your question, I know it is costly, but at least you can do a professional diagnostic CGM. You can offer that. So that is a blinded study. It's done for 3 days. So you ask the patient to keep the nutrition food chart completely, their activity food chart itself for 3 days. All patients can do for 3 days. You can have the professional CGM, you download and have the conversation. That's very effective and eye-opening. So I would highly recommend that for any difficult patient or any patient that's not willing to make the changes. You really want to teach them. And that it's a very effective teaching tool, CGM. Thank you. Any more questions? If not, I would like to invite our chairperson to felicitate our wonderful speakers today. I would like to invite Dr. Kumarvel to felicitate our chairperson.